Based on our preliminary reports and presentations that we have been doing since 2010 regarding the benefits of process standardization and physician support, we attracted attention nationally by commercial payers and by CMS for the model and the results that we achieved. Also, we had a good working relationship with the NCQA, which is pretty well respected as well. So CMS, over a couple of years of hearing presentations, invited about 40 people to come and serve in the technical expert panel for oncology payment reform. And it was a mix of payers, providers, the RAND Corporation people were there, Brookings, and so on. So there were discussions about what models to really pursue. Is it strictly a pathways program? Is it an oncology ACO program? Is it an oncology PCMH program? Those were the things that were discussed. And also it was obvious that CMS, like all payers, want to have a budgeted payment methodology where some of the risk is downloaded onto the providers. One of the things that we really emphasized in those interactions, which were more interactions between the meetings than during the meetings, was that before you can subject a provider and a patient to a budgeted payment methodology, you needed PCMH processes and services to act as a clinical safety net. And then the next question was, how do you protect the provider because of the lack of true risk stratification at that point. And even today, risk stratification in the OCM is going to be a learn as we go process. So they really kind of, I also served on Zeke Emanuel's Oncology Bundled Payment Consortium. And the OCM is really a combination of the work that was done in Zeke's panel on bundled payments and in the technical expert panel. So it's very PCMH rich. If you look at the eligibility criteria, it's PCMH rich. The outcome measurements are related to what you would expect a PCMH structured care delivery system to really drive. And it's a major first step. It's very broad. It's not limited to 2 or 3 different diagnoses, like some of the other early oncology medical home models were. This is really a broad spectrum of diagnoses because we are transforming our practice so that we can deliver care the same way to all of our patients, not just a subset. It would be like, if the subset is too small, it would be like telling a primary care physician who's signing up for a PCMH program that we're going to reward you for the good care you do with your hypertensive patients, but forget about your diabetics. You're not going to get rewarded. The idea is to treat everybody the same, put them through the same processes, collect the same data, have the physicians accountable for responding to the information, making changes, documenting, sharing, and communicating.